And now it's time for Patient Playback with Dr. David Tan.
Hello, everybody, and welcome to another episode of Patient Playback Podcast, where we're talking about practical things that maybe, just maybe, and hopefully the everyday working boots on the ground paramedic or EMT can put to practice in their everyday practice of pre-hospital medicine. I'm Dr. David Tan, Chief Medical Officer and Medical Director of the St. Charles County Ambulance District, and today I'm being joined by two fabulous guests, and I'm going to let you each tell the audience a little bit about yourselves. Let's start with Captain Law.
Andy Law. I'm a paramedic here at SCCAD, training officer, and served on the tactical team and served on the critical care unit, single resource, and just all-around EMS nerd.
But now, you also had a military background, though.
Yes, I was a corpsman for the Marines for 9 years, and loved every minute of it. Ground forces, did everything. So
awesome. Lieutenant Kramer.
I'm Jeff. I've been a paramedic here at SCCAD for since 2014. That's way better than math. And I've done a few other things. FTO for about a year and a half prior to becoming a lieutenant about a year and a half ago. And then served on other various things. Peer, awards committee, and then now most recently doing more of our outreach stuff through the Prevention Bureau.
Awesome. Well, thank you both for being here. You know, both of you as clinical leaders at SCCAD, and especially you, LT, you often work in the capacity of acting BC on the road, helping manage crews, run calls. I also believe in one shift you gave blood twice, I think.
Yeah, my first shift on 9610 when it was first available to us, I gave it twice. Both you were there for both of them, weren't you, Andy? Yeah,
that's right. Well, it just so happens the topic today is not necessarily about blood per se, although it will play a key role in our discussion, I think. But it really is about a growing concept, something that is really difficult, I think, for some people to grasp, which is not doing chest compressions in certain situations, even if someone is pulseless or in arrest. And I think probably one of the most dramatic shifts in the literature recently was the pre-hospital trauma compendium, which if you haven't seen that yet or are exposed to it, I highly encourage you to even just Google pre-hospital trauma compendium, and it should be the first thing that comes up. And it is a fantastic effort. Multiple organizations, the National Association of EMS Physicians teamed up with the American College of Surgeons Committee on Trauma, or ACSCOT, and ACEP, the American College of Emergency Physicians. And these are three widely known massive organizations that play key roles in helping to shape and form pre-hospital medical practice. And among the various publications of the compendium was one specifically about the pre-hospital management of traumatic circulatory arrest. And the title itself is a giant paradigm shift in that they are moving away from calling it traumatic cardiac arrest and instead calling it what it is, traumatic circulatory arrest. I think really kind of to help break that mental barrier of rethinking or re-evaluating what we're doing when we're resuscitating victims who have bled out, essentially, not necessarily medical, but from traumatic causes especially. And so even our protocols now for witness traumatic circulatory arrest, we renamed that, number one. And number two, we are trying to teach our paramedics to think about the difference between medical and traumatic causes of arrest. So what has been the feedback you two have gotten out there on the road so far, or how it's been accepted, or how they're talking about it out there?
As far as specifically the changes in
the whole concept of medical versus traumatic and compressions versus not compressions.
I would wager to say that there's not a lot of people on the road who are considering not doing chest compressions as a viable thing for a traumatic arrest. I think that might be something a little bit more new to them. As far as medical, we run those a lot more frequently. Might be kind of dark, but we almost consider at least severe, high amount of blood loss and a traumatic code and stuff. Almost futile. Yeah. A lot of times, but going through this, I think people will be excited to learn that, when we can get blood to the patient and go about it with a little bit different of a strategy, that we'll have a higher percentage of ROSC on those patients.
Yeah.
Yeah. With my background, I've always, trauma's been my bread and butter, and something that I enjoyed. It was fun to do, and in the military and everything coming out. If you would have asked me 5-10 years ago, changing the words meant nothing. But as I got to grow in a training officer, I learned that words make a huge difference. So the fact that you're just changing traumatic arrest and you're adding the word circulatory in there, it does force the provider to say, hey, does this make sense? And what I can appreciate in the civilian sector is we've transitioned from just algorithms, right? It was just an ACLS algorithm. All right, it's just tachycardia, is this PEA, and all these other things. And unfortunately, trauma was just an algorithm. So the minute that anybody fell into traumatic arrest, they just shut their brain off and let's follow the algorithm. Let's do epi, chest compressions, and then wait till we put in a rhythm that we know what to do, asystole, and then call it a day.
And then call it, yeah.
And so now that trauma's gotten attention from everybody, because I think people are transitioning out of the military and they're going into these private sectors and civilian sectors. Mm-hmm. So they're bringing that experience. And so we're seeing a lot of evolution in trauma, because I had the privilege and opportunity to train this particular subject at our agency for the first time. And as I'm talking about it, and as I presented the protocol up, you see a bunch of jaws drop. And as I talk about it, they're like, this makes sense. And there wasn't, and I would, hey, anybody got a rebuttal? Anybody got, no, they're like, no, this makes sense. I never thought about it. And they always just followed a traumatic algorithm. Yeah. And now we're forcing them to think about it. Hey, you're working a trauma call. What's causing this? What are we doing to help this patient? We're not just doing things because it's a checklist. We're doing things because it's helping the patient. And so if chest compressions is hurting the patient, we shouldn't be doing it.
Right.
And so I can greatly appreciate the attention that this is getting, and just the minor changes and just adding the word circulatory into it. So
yeah, I love that feedback, because I know, especially here at our agency, it's at SCCAD, our clinicians pride themselves on being really good diagnosticians, which means they're very good clinicians. And one of my favorite sayings that I stole from another colleague of mine years ago is that we don't bring patients to healthcare, we are healthcare.
Yes.
We bring the healthcare to them, which means we got to move away from algorithmic thinking and really start putting critical medical decision making together. And really, the success of a traumatic circulatory arrest protocol is incumbent upon paramedics who are willing to be really good clinicians and diagnosticians to apply this. And I think, especially in the age where, or for agencies who have access to pre-hospital blood, this whole entity, this whole pathology changes for us, because now the primary problem, exsanguination, can be addressed before getting to the hospital, which before just very recently was impossible to do and wasn't even thought of as an option. And I think that really is changing the conversation now that you have pre-hospital blood programs. I do want to be quick to point out that for anyone listening who may not be at an agency that has pre-hospital blood, the situation doesn't mean it's impossible. There are other things you can do. And I saw this acronym, which was very helpful, at least I thought, HOTT to reversible causes, which is H was hypovolemia from hemorrhage, of course. O was oxygenation, T, tension pneumo, and the other T, tamponade. All of which are things that as pre-hospitalists, we can do something about. And so for hemorrhage, probably first and foremost is, if you use XABC, is try to control controllable hemorrhage. Now, obviously, if somebody has a splenic injury or liver injury, there's not a whole lot we can do in the field, at least not yet. But certainly, we've all run those grinders or motorcycle crashes where you've got partial or complete amputations, peripheral exsanguination that we can control. Getting that tourniquet on, stopping compressible hemorrhage, packing junctions if necessary for these really bad injuries, and then hopefully being able to then get blood there if you have access to it to fill that container back up.
Yep, and you talk about HOTT and XABC, though. With the military side, the first thing I was introduced to was MARCH, the MARCH algorithm: massive hemorrhage, airway, respiratory system, circulatory system, head injuries, hypothermia. One of the guiding principles of MARCH is it helped reduce the bandwidth and the processing power. It allowed you to make intelligent medical decisions in the advantage of the patient. And so one of the key things of MARCH is you wouldn't do anything in the following letter that would compromise the first letter. For instance, you wouldn't do an airway intervention when massive hemorrhaging is still going on. It prioritizes it. And so one of the things we came up with at our agency to help guide the treatment pathway and priority is, in the absence of blood, we would maintain MARCH. With the blood product in play, we would move on to what we call STOP, right? Which is stop the bleed, your transfusion protocol, oxygenation, and maintaining the thoracic integrity, and then head injury, hypothermia. But for an agency that doesn't have blood, that still applies even in the decision making. And what I mean by that is with MARCH, you could do interventions to stop the bleed or put blood back into the system. But you also don't want to do anything to make it worse.
Yeah. Right.
And so if we're doing chest compressions in somebody that's massively bleeding through an organ, you're compromising the M part. You're not stopping the bleed, but you're also exacerbating it by increasing the pressure, increasing everything, and making them bleed worse. Right.
But that's so hard to do, because when you think about it, we're all just almost hardwired to start compressions when someone's pulseless. But in this case, and that's why I think understanding the pathophysiology behind it will help buy in a lot more. Yeah, even especially at these agencies that don't have blood, to understand why it's so important not to paradoxically make the situation worse by taking maybe what little blood they have in the tank and shoving it out the whole fascia onto the ground, onto the floor, if you haven't gotten hemorrhage control first. Which is why I think HOTT to reversible causes starts with hemorrhage control from however you can, but then go to O, oxygenation, because that's really going to be key. Going to the airway, making sure they're breathing. And these are all, a lot of this stuff is great BLS maneuvers that can just improve oxygenation, make a patent airway. I think a lot of practitioners, when they see this hot mess in front of them of just carnage, sometimes they can just go for the most obvious or the most spectacular injury without thinking about these fundamentals. Like, hey, how about we just some pressure, some hemorrhage control, BLS airway maneuvers, get them oxygenated again, because that is really fundamental to the resuscitation of this person.
Yes. Yep.
And then T, tension pneumo, which of course in some of these situations, especially if they're already in arrest, you're not going to be listening to breath sounds, for goodness sakes. if they have the mechanism, certainly if they have clues like crepitus or anything like that, bilateral needles, bilateral finger thoracostomies, and then a lesser, but still on the T, the second T being tamponade. So one of the things that we are fortunate enough to have here at SCCAD as well is point of care ultrasound, or POCUS, and our single resource critical care medics. Many of our battalion chiefs have access to POCUS. We don't have it, unfortunately, on every single ambulance yet. But, the thing about POCUS is that it's not like a simple 20-minute in-service and here it is and you're good to go. I mean, it does take a lot of training and credentialing to be able to use the thing, because there is a lot of training behind it. But have you seen POCUS used in the field yet for a traumatic arrest? I know we use it quite consistently for medical arrest, but I don't. Have you seen it deployed for traumatic yet?
I haven't, but I will tell you, as I'm sure you already know, like some of the steps, like a pulse check, right? POCUS just makes so much easier, because as soon as you stop CPR, the critical care medic or whoever's running it sees that blood exchange stop immediately, and then you can continue going. So those things that we used to reserve 10 seconds off the chest for is now 1 second off the chest.
Yeah.
I don't see it very often in the trauma. That doesn't mean I'm against it or there's not a place for it. I will say probably within our culture, the way that our system is built, just where the hospitals are at, there's so much going on that in our way of patient care, it's only confirming what we already know. And so I could see, in a rural environment where you have a longer transport time, like maybe knock out that fast exam and see, hey, we have blood here or whatever. But for our system, with our trauma centers being so close, and we have the luxury of having 3 trauma centers, and one of them is probably at most 20-30 minutes away, and there's so much for us to do, including putting on blood products. We doing a fast exam is only for us. Will either take up a hand from starting a line, helping with blood, helping with an airway intervention, or just confirm something. Yeah, I already knew his freaking liver's exploded because he got smoked by a semi. And so I'm not saying there's not a place for it. I'm not saying anything negative against it. I'm just saying it's not happening in our agency just because of this circumstance that we're in.
Well, I think one of the most important takeaways for technology, especially in trauma or any application, frankly, is knowing when to use it. And I definitely agree. I don't think the ultrasound is the first thing you would reach for in this situation, because you're going to be really busy doing HOTT and T first, right? Yeah. But actually, that last T includes a really unique role for POCUS, in that you could, like, if you suspect a tamponade, you could very quickly ascertain whether they have a significant, hemodynamically significant tamponade or not with POCUS relatively quickly. But to your point, LT, it's got to be done fast. You're not going to be sitting there for 20, 30 seconds not doing anything, looking for something. I mean, it has to be done quickly, which is why probably certainly someone who's credentialed, but the most experienced person also should be doing it to minimize pauses or minimize interruptions to answer a specific clinical question. But I think knowing when to apply the technology is just as important. I know that here we're trying to replace pulse checks using POCUS, because no matter who you are, doctor, nurse, tech, we all suck at pulse checks.
Terrible.
I mean, the study after study has shown inter-rater reliability is awful, and some people are better at palpating than others. And how many of us have been on scenes where we're like, I don't know, do you feel a pulse? I don't know, I think so, do you? And we're eating time that we don't need to be. So knowing when and how to use it for pulse checks is also really important. But in specifically talking about trauma, I think, especially for the last T in HOTT, this tamponade, there is a role for it, but if you know how to do it quickly without doing a lot of interruptions.
And I think honestly, from what I know about the ultrasound and the cardiac tamponade is probably one of the easier things to distinguish. It's not as very specific in millimeters, because if you get that cardiac view, you're going to see the pericardium, and then you see that black space, and then the heart tissue.
Right.
And so automatically you can assume, hey, we have and so that's a really quick thing. It's not like, when you're trying to catch other views and valves and stuff, you're moving millimeters, micrometers, and it's very specific. This one, if you're looking for cardiac tamponade, the minute you catch that cardiac view, you're going to be able to distinguish like the hyperechoic, and then that's this black space. And the heart, you're like, okay, there's something in between there that's not supposed to be there.
Right. I think bringing all these tools together will completely change the way we manage major trauma, but especially those in arrest. Now knowing what order to put this all in is going to be just as important as in overall management for traumatic circulatory arrest. I wanted to talk also about the fact that at some point in time, especially in services that have blood, like ours, we try to minimize scene time as much as possible. And the reason being, of course, that major traumas, they need a trauma center, because there's very few things we can do in the field, even in the emergency department, for a major trauma patient than getting them to an operating room with a trauma surgeon. And so to help kind of minimize those things that prolong scene time, what do you do, for example, on the scene of a major trauma to help kind of keep the team together? What do you do for team dynamics as far as making sure that we're constantly progressing forward and getting off the scene as soon as possible?
We use the word pit crew a lot in training and stuff here. And I think, which kind of the TLDR of that is every person has one job that they're comfortable and capable of, and a position to be in around the patient, and then can execute that without any kind of muddiness or miscommunication or anything between the group, and then having one lead, which is usually your BC on scene. So I think I'm pretty good at keeping the calm. I think that helps a lot.
Yeah.
But then you got to think outside the box. Maybe it doesn't make sense to wait for your blood product. It makes more sense to have a rendezvous somewhere else on the way to the trauma center. And that is less time than just waiting for that blood vehicle to get all the way to you.
Right.
I hope that answers your question.
I love that concept, because as more and more EMS services begin to find ways to have pre-hospital blood, because honestly, I don't think there's any question now that replacing blood lost with blood is way better than replacing it with salt water. Right? I don't think there's any argument about that anymore. Now, the unintended consequence might be prolonging scene time when you've got the go as soon as possible. And I know we've done rendezvous multiple times, and that does save a ton of time. But it takes, to your point, having someone who's in charge, having a leader that is keeping track of the big picture, because frankly, the attending medics are going to be in the weeds doing their thing, doing their pit crew assignment, their assigned task. So somebody has got to be minding the time and kind of, like you said, keeping the calm, making sure that everyone's got a job and is doing it, but also thinking it 2 or 3 steps ahead. Like, okay, this person clearly needs blood, but we're on this side of the county. The blood BC who's got it is on that side of the county, but we got to go that way anyway for the trauma center. Hey, perfect time for a rendezvous, right? Get off the scene, get going towards the hospital, do a very quick meet and greet, jump in with the blood products and go. And you can do the blood transfusion en route.
Now, and the times that we've done an intercept, has dispatch helped with that, or is it entirely been
Yep. And so
units?
One of the things I think that contribute to what you're talking about is words matter. We talked about before. So when we launched the blood program here at SCCAD, I had to reframe how people thought, because when they ran trauma, they thought we've been programmed is time is the objective, time is the goal, that what we're fighting is time. And what we reframed is, hey, let's just talk about efficiency. Now that we have blood, before when we didn't have blood, it was BLS care, transport is medicine. And so like we made the transport medicine efficient by loading them up and going and doing everything en route. Mm-hmm. But now that we have blood, that's a treatment for trauma. And so we look at the efficiency of getting blood into that patient's vein. And we know it's national standard that it's around 20 minutes, best estimate, 20 minutes when you hit that ER door, that blood's going to get in that person's vein. But we could be more efficient in it when the BC gets on the truck. Mm-hmm. We already have an IV established. We do our med check. We check our blood all the time. It's there. We could be way more efficient in administering blood in the pre-hospital sector and in the, as opposed to like the hospital sector, where they go through registration, make contact, and all those things. Even with uncross-matched MTP, it's still roughly a 20-minute hitting the vein. Mm-hmm. So when we reframed, hey, all we're doing is I want you to think about how to make it more efficient to get blood in the vein than being efficient in transport. And so changing the problem for them to solve is like, hey, can I get, and studies have demonstrated, like if we could get blood in this vein 30 minutes after the point of injury, it increases the 30-day survivability remarkably. And so if you can get blood in this person's vein by one way or another, whether it's going 2 miles out of the way, whether it's, hey, waiting here for the BC to get here, or whatever it is, if you solve that problem, then deal, solve it. But if you cannot solve that problem, that there's no way I could get pre-hospital blood in this person's vein in 30 minutes, get to getting. Going back to our old BLS care and transport rapidly right away.
Right.
And so basically we just gave them a new problem to solve. The problem to solve is not how fast can I get off scene. The problem to solve is how fast can I get blood into this person? What can I do to do that? And so we don't make, oh, you can only travel 5 miles out of the way, or you get, because 5 miles during rush hour traffic is completely different than 5 miles at 2 a.m.
At 2 a.m., yeah.
And the weekend and so on and so forth. And so we give the provider latitude to make a decision. We gave them a new problem to solve, which is, hey, efficiency of care. And that has been remarkable. Because we've had literally the way, we have 2 arteries to get to a trauma center. And we've had instances where normally by the bird flies, it's more efficient for the crew to take a highway. But where the BC is coming from, they can make the argument to take, we're going to take the other highway and we're going to intercept along the way. And BC jumps on board and we'll dip out and get blood in it. So numerous times crews have problem solved that situation. Yeah. Solving the problem of, hey, how do I get blood in this guy's vein in 30 minutes?
I love how you frame that, because our crews inherently really are problem solvers. Yeah. They're great problem solvers. And once we've given them this new tool, they have figured out a way to use it most efficiently and practically. And it's been truly gratifying to see the program grow as it has. I think it's important to remind listeners who may be at an agency that don't have blood products, you still want to think about time, but think of movement as medicine.
Yes.
And if you think of movement as medicine, which is true, especially in the case of major trauma, then that is a much more holistic way, I think, of looking at time management, other than time being your enemy. How do you use it to your advantage? Get off the scene as fast as you can. Do immediate life-saving interventions that they need right then and there, and then go. And then eventually, if you have the ability to do blood products, well then, great. Factor that in. What I think is cool is that there's always been this, when we talk about controversies in blood, what's better, whole blood versus component therapy? Here at SCCAD, we have component therapy because that's what we have immediate access to with our supplier, at least at this time. And the cool thing is, just a few days ago, I mean, hot off the presses, the New England Journal of Medicine published that sub-study from Frank Guyette and colleagues, and basically showing that whole blood and component therapy 30-day mortality is essentially the same. So in other words, it's equally good. In other words, this is good news for EMS in that, hey, you know what? Don't stop worrying so much about what kind of blood product you're giving, whole blood versus component. Just get blood, whatever is most accessible to you. And you don't have to worry about, well, am I giving the best possible care for my patients? Now the answer is yes. We have data that suggests, you know what? Anything is better than saline. And whether it's whole blood or component therapy, mortality is equally good. So I think that's good news for EMS in general.
And that's the second study that came out. And the thing about that study is it's Tower.
Yeah, Tower.
But the thing about that's the second study and the first one is it's not in the conclusion of the summary. It's in part of the where they go into details.
Yeah.
And they demonstrated it's statistically insignificant or not statistically significant of the difference. There is a difference, but not enough to like I have to go this way.
Exactly.
And so it's just evidence of a whole blood or component therapy, whatever makes sense for your agency. The benefit's still the same for the patient, and it's gonna increase the survivability.
Right.
All day.
I think traumatic circulatory arrest, I think our statistics are definitely going to change as more and more agencies get access to blood products, whether it's whole blood or component therapy. I know that we recently celebrated a case where the patient and she was incredibly gracious in allowing us to use her name and her likeness, her story. In fact, she helped recruit donors for our recent blood drive here, which was awesome. But you know, I am fairly confident to say if this happened 6 months ago before our blood program, she most likely does not survive that crash, but now is able to live a full and happy life with her family. And I think that's one of the most gratifying cases that our clinicians here at SCCAD have been a part of and is really, really excited to see.
So one thing I want to parse out, because I have the benefit of serving in the military capacity and the civilian sector is, you know, whole blood, the blood program in itself, prehospital blood was the military thing, right? Mm-hmm. And so there was a lot of stock in whole blood therapy. Rightfully so, because if you think about industry-wide, like in the military, hey, I'm going out on a mission. What I'm going to do is I'm going to draw blood from you into a packet or into a unit. We're going to go on that op. If we don't use it, deal. I'll just put that blood back into you. I don't have to spin it, don't have to do anything. It's just efficient. It was way better than what anybody has offered. So they took that in the civilian sector and it carried like whole blood is the standard. Everybody wants to strive. We were guilty of it. We wanted whole blood.
Yeah.
But in the civilian sector, especially with the demonstrating, hey, there's not much difference between whole blood and component therapy. I think it makes more logistical sense in the civilian sector to go with component therapy, right? Because your PRBCs are going to last, the shelf life is a little bit longer than whole blood. Your plasma is not as long as a shelf life, but it's actually less expensive. Mm-hmm. And so things are going to expire individually, component-wise. And sometimes, you know, there's growing evidence where there's value in just plasma administration alone.
That's what I was going to say.
And so the civilian sector, I think plasma or component therapy is kind of getting a bad rap, and I think it's that bleed in from it's efficient, 100% makes sense in the military, but on the civilian sector we have labs, we can drive to the lab and get blood, and we get things expired, and the price points are different. Mm-hmm. And so if you're an agency thinking about going with a blood program, don't think that you have to go with a whole blood program. Like you can easily, very well. I mean, if you want to start and just do plasma, that in itself is better than just saline, and you're giving an option. It's, you know, for us, it's $60 a unit of plasma. Shelf life roughly about 20 something days, and so that's a good start. And you can demonstrate proof of concept in that. And
I think there is a growing body of literature now that will support that concept. Yeah. And which again, the bottom line is, it's good news for EMS services looking to do this, perhaps. And it increases the accessibility to pre-hospital services to get whatever they can. And for example, for us, component therapy was really the most accessible thing, and it's been working fabulously. And so, yeah, I think that's good for us in the industry in general. And I'm excited to see how the data grows as we get more and more patients to feed into the growing body of literature that supports blood therapy pre-hospital. In spite of having all these increasing number of tools and strategies to save patients' lives, traumatic circulatory arrest, as we started at the top of the hour, is known to be pretty abysmal as far as survivability. Thankfully, I think it's gonna get better as time goes on, and we get better at managing traumatic circulatory arrest, especially with tools like blood and component therapy. But survivability is still gonna be pretty bad. So having said that, I think it's important when we talk about this topic to also discuss field termination criteria. Like when do you think it's reasonable to try, transport, and get to a trauma center after or even during circulatory arrest? And when is it likely reasonable to say this person is not salvageable and we're not going to risk transport? Probably, what do you think about that?
End title probably plays a big role in whether or not you decide to continue.
Yeah, I think it's going to be one of those curves, right? I think, when we talked about medical, you don't treat every medical patient the same. A COPD patient, a CHF patient, like we parse it out.
Yeah.
When we talk about trauma, it's like, but dude, getting shot, a diving accident, being electrocuted, like these are remarkably different ways traumatically that you're dying from, right?
Yeah.
Also, in a trauma patient, like a medical patient, it's medical. Your heart was injured. If somebody's dying from that, they've done compensated. We have drove that 1985 Toyota Camry 300,000 miles.
Yeah.
But in trauma, they're happening to young males that are making poor decisions but are healthy. Mm-hmm. And so their resilience is going to be a little bit more remarkable. So I think when we're terminating in the field for a traumatic injury, we really need to be looking at, does this make sense? Instead of just following an algorithm, right? Because I go back to thinking about that one officer in North County that was shot and hearing the story of him arriving at Big Barnes, he was bone dry, not a lick of volume, goes to the OR, gets blood dumped into him, and gets discharged in 3 months. And so, our patient that was in a car accident, you looked at the scene, you looked at the patient, initial impressions, there's no way, right?
Yeah.
But no additional comorbidities. It was a traumatic accident. We gave blood. So I think people are resilient. So some of these things that we're seeing that nobody's surviving that, as we're giving trauma the attention it deserves, we're going to see that it doesn't follow a playbook. Somebody could get smoked by a semi and survive, and somebody could have a 5-foot fall from a step stool and die. And so we just have the tools. I think it's for trauma, it's more important to have priorities and principles than an algorithm.
Yeah.
Right. And so hey, priority is bleeding. It doesn't mean I only do bleeding, but it's a top priority. This is going to kill you first. And as you run down your priority list, it's going to help you make a sound medical decision, as opposed to not making a decision at all and only doing an algorithm, or I'm guessing. So as we're learning more about trauma, we're learning how resilient people are. And that's the thing is, a CHF patient is generally going to present the same way across all demographics, because it's pathophysiology, right? But the pathophysiology of a 33-year-old involved in a motor vehicle ejection versus an 80-year-old involved in motor vehicle ejection is two completely different things. Osteoporosis, heart, and all these things. So we have to take those into consideration. And so it's not this broad stroke, hey, now if they're decapitated, deal. You're not going to be much resilient from that.
Right.
But I think, as we start giving trauma attention, you're gonna be splitting hairs.
But it goes right back to our one of our opening concepts, which is EMS is by itself a unique practice of medicine. And EMS in the beginning, when we first started, was very much algorithmic. And it had to be. But now that EMS is its own subspecialty of medicine within the House of Medicine, paramedicine is also very much more moving towards a unique practice of medicine in itself. You do have to be much more complex in your medical decision making. And in the case of traumatic circulatory arrest, you do have to take into consideration, is it penetrating trauma or is it blunt trauma? Because that also is two completely different animals. And then proximity to a trauma center, prolonged extrication or not. You mentioned end tidal, and that's something that we haven't talked a whole lot about yet, but it is very much key, I think, as well. We definitely talked about technologies, including POCUS, but really capnography is probably one of the most important things in any resuscitation, whether it's medical or traumatic.
Reversing shock.
Exactly.
Right.
And whether or not cellular respiration is even happening.
Yes.
Right. Because you could have all the blood in the world, but if you've got excellent, you fill their tank and you've stopped the source of hemorrhage, and they're asystolic still, and their end tidal is 5 or 10. Right. That's way different from someone who you do all these things and now their end tidal is up to 45. Well, that's somebody that I would say, let's go. Yeah. Let's get off the scene and transport as soon as possible. So presenting cardiac rhythms, mechanism of injury, time to a hospital, these are all complex things that have to be taken into consideration as far as, do you terminate in the field or do you actually go through the risk and logistics of transporting somebody? And I think here at St. Charles County, one of our both challenges and opportunities include the fact that we're so diverse in our population, but also where they're spread out from, because we are at the same time urban, suburban, and rural in every part of our almost 600 square miles of the county. And so all of these things are being taken into consideration. And as we also led off with, was the importance of teamwork, team leading, closed loop communication, and having somebody keeping an eye on the big picture for these very complicated scenes.
One part, so you said the word team, right? And we get, in our occupation, in our role, we really put a lot of emphasis on the patient. But as a leader, the team event ultimately ends up being our patient, right? So not just the patient that's sustained injury in front of us, but the team members ourselves, like, that's my patient. Like, I want to make sure that they're doing it right. So we talk about decision making, and we talk about, you make decisions one of 3 ways. The first one is using your brain. That you're going to analyze and do things highly accurate, but it takes a little bit longer. Next thing is using your gut, where it's like, man, I don't know the right answer. It just feels right. Like, this is the way to do it. And then the last one is your heart, right? And so it's like, hey, I want to do this because it helps me sleep at night. And so when you talk about transporting or terminating on scene, every team member is different. You're going to have a trauma patient where 3 of the 4 members are making either whether a gut decision or a head decision and saying, hey, like, this guy's done. And that last team member is in that heart mode. And it's like, hey, we just have to transport this 5-year-old kid. Like, I can't not do something, right? And I offer our team, I said, hey, if that heart decision isn't impeding something or causing harm to somebody else, let's give them that, right? Yeah. Like, because that's going to help that might not be that provider's last day. That might, by doing these things, right? And so sometimes we will sit there like, oh, that's not the right answer. So we're making a decision with their head, but one of our team members is in that heart mode. Yeah. And so we have to consider that. And you know, if it's that traumatic call and you're like, hey, deal, you know, what's the harm in this? Short of I'm transporting a guy without a head again. But like, if it's like, hey, you know, end title's 5, been 5 this whole time, but it's this 8-year-old kid. It reminds him of this 8-year-old daughter that our team member has, and we just need to transport. And it's a controversial, but I would say let's do that.
Well, I absolutely think that part of a well-rounded system is taking that very thing into consideration, because our medics are not robots. Nope. They're human beings with families themselves. And I love how, especially in a conversation about traumatic arrest, from the other side, from the patient's perspective, their families are going to be devastated. And we see the worst of the worst sometimes, especially in trauma. And our clinicians who have to live with these images for their career, something that I really appreciate about SCCAD is that we have processes in place to address the very thing. Not only fatigue scores that we calculate and try to give crews a protected time off just to recuperate mentally, but psychological timeouts as well. I know, LT, when you've been out there on the road as an acting BC, and certainly our BCs out there, you have the discretion to take a unit out of service if they have suffered a psychological trauma because of a really bad call. Regardless of the trigger, it doesn't have to be pediatric. It often is a pediatric call, but it doesn't have to be. Like Cap said, it could be someone who just reminded them of a family member. You can tell that a particular crew member is being really bothered by this particular scene. You have the discretion to pull them out of service for a moment and make sure they get the psychological help they need and do a hot wash at least or talk about it. And that's something that I've always appreciated about our agency is that we have no problems doing that. And I think we probably need to be on the lookout for that even more to make sure that our crews don't suffer down the road. Yeah. Because it's not always one scene. It's the cumulative effect of all these scenes. And I'll tell you what, even our happy scenario where the patient that we talked about earlier lived and was discharged back to her family, it was still a pretty bad scene of carnage, and she looked like she was dead.
You would have guessed. Yeah.
You would have guessed that she was going to be dead, and that image is still in their minds. We need to be cognizant of that and do that. What are some things that you do as road leaders to kind of mitigate the psychological trauma that our crews will see on scenes like this?
I'm big on check-in, even like throughout the day, like not even just after a traumatic call, but like, maybe it's something secondary at home or going on in their personal life, whatever. But man, we are liars about that kind of stuff. I'll ask guys all the time, or girls. I say guys as like the,
generic.
Yeah. And we're terrible about doing, no, I'm fine, LT, or I'm good to go. And like, you can see it in their face that they're not. And I think that visually is important. And sometimes you can pull it out of them and get them on their own, or even just kind of doing that hot wash after action report, and also coupling that with positive things, not just like constructive stuff. Because no matter how, especially after a scene that really messes with somebody, it doesn't matter how constructive you are. If we're only talking about mistakes, then that just sticks with them. So I'm big on like the 3 sustains and 3 improves is what we learned when I was in the Army. So I try to do that sometimes, but yeah, I like getting a chance to take care of somebody when it comes to their mental health, because I think we've all struggled with it at one point or another.
Yeah, I think to his point, we are a different beast, and I'm big on tribe. So I don't want to talk about the problem. I don't want to talk about, to me, it's rehashing that. I'm picking that as SCCAD, right? But going through something together with somebody else, anybody could go through anything horrible as a team. Going through something horrible on an island is the worst, right? So to me, for tribe is just the presence of, hey, let's go we don't have to talk about it. Let's go get coffee. Let's go get something. I'll sit with you. We'll talk about anything you want to talk. You want to talk about that? Deal. We'll talk about it. But just the energy and the presence. I mean, you sit sitting in a room with people having a meeting versus sitting in a Zoom meeting. Like there's something to be about that physical connection, the energy of physical presence. And so I think just say, well, when we talk about the call, let me just hang out with you or talk about anything. Even just, I come home and Lori and my wife, if I had a long day, babe, I don't want to talk about, but let's sit and watch a movie. And that feeling of her there watching a movie with me versus me sitting in the bedroom by myself watching the movie, completely different beasts, right?
Yeah.
And so just having that tribe together, keeping together. So for us, that one of the things when we were developing the mental health policy and like scoring out of these, one of the things was like, hey, we're going to send these guys home because the chance of them running another call is there. I thought I had made a campaign like I don't think that's the right answer because you ran a call with your partner. That's your tribe. You've been through some hardship together, shared hardship, and now you're peeling them away from each other. The only person that could understand that shared this experience with you, sending you home to your wife that's a freaking Sunday school teacher that has faints at the sight of a nosebleed, and there's just no connection, right? And so now we're all in favor of, hey, let's sit at the base, share a meal together, but go out of service, right? So it's that tribe mentality. And for me, that's just, it's gone a lot because I am the furthest thing from a therapist. Like I don't have a track record of talking anybody off the ledge. But I could be there with you and we'll fall off the ledge together.
Yeah.
So, but as a leader, I think that's so important and a strength that you have of being able to let people decide what they need and then doing your best to adapt to that as a leader. I think that's a remarkable trait of a good leader, somebody who isn't just like a one-trick pony when it comes to being good at leading one particular learning style or a subordinate style, but somebody who can adapt and move around to how they lead or train or do anything for a different type of person.
Yeah, I love that. And I think just even talking about the concept of psychological first aid for your crews is a gigantic leap forward, I think, in EMS in general, because we've never really talked about that a whole lot before. But especially in traumatic circulatory arrest, psychological first aid should really be part of our strategy for dealing with it, because either way, our clinicians are going to see some pretty rough things, and we should at least be aware of it. And especially all of you out there on the road with your people every day, you know your people better than anyone else, and so really, especially for you, LT, you're going to be at the tip of the spear, knowing, being with that same shift, that same crew, that same general area all the time. It's going to be super important for you to have that ability to recognize, just as you said, you can just tell in their face that they're lying. Mm-hmm. But just because you recognize that even gives you an advantage, because now you can do something about it, versus someone who doesn't know them and believes that they're fine and then walks away and loses an opportunity to help future burnout just by not giving them that out or being with them, like you said, just being with the tribe. Because sometimes that may be all you need. Not every single debrief needs a formal psychologist to talk to. Sometimes you just need to talk to your buddy who was there with you. But at least you'll be able to recognize someone who needs more. You know?
And people need to know that they can heal from that. It can feel really draining and distant and dark to have those triggers or those nightmares or whatever it happens to be for that particular person. But what we do know is that brains and bodies and stuff can heal from that kind of trauma. So you gotta let people know that there's a way out, so that they're not compensating with alcohol or other stuff.
Very unhealthy things.
Yeah. Mm-hmm. Well, and also, as we talk about this, to segue kind of back to the patient-centric part, we talk about termination on scene. For pediatrics, I'm a huge proponent in transporting that. I know a lot of agencies and people that we're nameless, we don't transport dead people. The thing is the hospital, pediatric centers have resources for mothers, fathers who've
Family.
lost. Yeah, like there's social services. There's a remarkable support system that's 5-10 miles away, as opposed to now, we're going to call it. So you're existing in the room that you've lost your child in, that is his bedroom, and maybe you're lucky enough to have a chaplain. Maybe you're lucky enough to have a sheriff that's had CIT or something there. But like, to be able to take you down to a pediatric center where there's people that deal with pediatric deaths, that know how to support families, give them resources, and love on them and stuff like that. I think that's just as important. And so, I don't think that we're there yet for adults, but I think for peds, sometimes the right answer is let's just.
Pediatrics definitely way different beast,
Yeah.
I think, in that regard. But I think that's a very good point as well. This whole, as I think about key takeaways, boy, we made some really good points at this.
Our podcast needs Adderall. It's like, like everywhere.
No, I think the traumatic circulatory arrest it is a very complex beast by itself and with its own problems. But I think definitely some key takeaways include the fact that traumatic circulatory arrest is way different from medical cardiac arrest, where the heart is the problem medically, but from trauma, the heart's fine. It's a volume problem or a pipe problem. I think that's one key. I think making sure that we remember the reversible causes, whether you're a BLS service or an ALS service or BLS clinician or advanced or critical care, it's still HOTT to reversible causes. H, stop the hemorrhage. O, maximize oxygenation. T, do reversible things, fix reversible things like tension pneumo or pericardial tamponade. I think remembering another key takeaway is we can't be so dependent on technology that we kind of get blind to its downsides and start increasing pauses between key interventions and losing track of time. If you've got ultrasonography, great. Know what it's good for, know what the downsides are, use it appropriately, but don't be prolonging scene time because of it. End-tidal CO2 is a key tool to also help make decisions. And when it comes to decisions for termination of resuscitation, I think one of the key takeaways we talked about was making sure that you really take the sum totality of the circumstances in mind. Penetrating versus blunt. 5 minutes from the trauma center, like the North County officer was, versus 45 minutes running hot from a rural corner of the county. We talked about that whole decision process and the ethics of it. And then also, to put a cherry on top of the discussion, remembering our own colleagues and ourselves. Traumatic circulatory arrest is often accompanied by really bad scenes. And it may not be the one, but years and years and years of this managed incorrectly leads to early career failures, burnout, substance abuse, and lots of family strife and problems that we really don't want for our clinicians who are looking for a long and happy career in pre-hospital medicine. Have I missed anything else? Any other key takeaways we talked about?
Sure.
Guys, Captain Law, Lieutenant Kramer, really appreciate you joining me today to talk about such a complicated topic.
Thanks for having us.
Thank you. Awesome. For those of you who are watching on our YouTube channel, be sure to check out our other topics that we have on our channel. Thank you for watching, and we'll see you on the next episode of Patient Playback.
Thank you for joining us today. Be sure to like and subscribe. You can download our podcasts on iTunes, Spotify, and more. And of course, you can find us on your favorite social media platforms. Links are in the description section below. Patient Playback is a production of St. Charles County Ambulance District.